Good morning and welcome to the TMA International Virtual Myositis Summit. My name is Rohit Aggarwal and I will be talking about role of autoantibodies in the management and prognosis of myositis. Let us first discuss some learning objective for today's lecture. First, what are myositis autoantibodies? The importance of myositis autoantibodies and the key role of myositis autoantibodies in the diagnosis, management, and prognosis of myositis. Please note that this lecture will not cover inclusion body myositis or IBM, although IBM also has an autoantibody called anti-CN1A antibody. And the reason is that although IBM has this antibody has not found to be useful clinically so far. So let's discuss what are myositis autoantibodies. To understand what are myositis autoantibodies, we must first define what is an autoantibody. An autoantibody is an antibody which itself is a special protein in our body produced by the immune system that is directed against one or more of individual's own protein. Essentially, it's a special protein called autoantibody that is directed against one of our own protein by our immune system. Different autoimmune disease has different autoantibodies. For example, rheumatoid factor is an autoantibody seen in rheumatic arthritis, and ANA is an autoantibody seen in lupus. Similarly, myositis autoantibodies are simply these autoantibodies seen specifically in myositis patients. So, in other words, you can say that myositis autoantibody is a special protein that is produced by the immune system of myositis patients against one or more of individual's own protein. In next several slides, we will understand why these myositis autoantibodies are important. Myositis autoantibodies are highly specific. Now, what do we mean by being highly specific? We basically mean they are highly specific for the underlying diagnosis of myositis. Therefore, typically, myositis autoantibodies are only seen in patients with myositis and is not seen with other autoimmune or non autoimmune diseases. Therefore, having myositis autoantibodies can help in making a diagnosis of myositis. Next, the question is how specific is this high specificity? Jo1 antibody, for example, is highly specific and is the case with all other myositis autoantibodies, and its specificity reaches more than 95%. That means if a patient truly has a positive anti-Jo1 antibody, which by the way should not be false positive because sometimes some assays give spurious results. But barring some spurious result, if patient truly has a Jo1 antibody, that means that patient probably has an underlying diagnosis of myositis. Now, we often see that autoantibodies could be present in patients with autoimmune disease far before, even years before, they actually develop a clinical syndrome or clinical features of that particular disease. And so, the same is applicable to myositis patients as well. However, these myositis autoantibodies have poor sensitivity on their own. What do we mean by poor sensitivity? That means in the whole world of myositis patients, one particular autoantibody will be discovered in only a minority of the patients. The best sensitivity we have is actually for Jo1 antibody, and that could maximum would be about 30 to 40% on an average. So that means amongst if I have 100 patients with myositis and I only test them for Jo1 antibody, only perhaps 20, 30 or maximum 40 patients would be positive. Therefore, having a myositis antibody almost certainly puts the patient in that particular diagnosis, but not having a myositis autoantibody does not rule out myositis as the diagnosis. Now, fortunately, we have many myositis autoantibodies discovered. So, although individual myositis autoantibody may not be present in that many patients, but collectively, if we do all of the myositis autoantibodies testing, that means we testing for not just one antibody, but all of the available myositis antibody, the sensitivity actually increases to about 60 to 75% depending on the center. Now that means if we have 100 patients with myositis and I have availability of testing all myositis autoantibodies, I could actually make a confirmed diagnosis in about 60 to 75% of those patients. Now this is highly powerful because now not only we would have high specificity, we would also have reasonable sensitivity if we use myositis autoantibody as a panel or do all of the myositis autoantibody testing. Now, as you may already know, there are many subtypes of myositis, such as adult polymyositis, called PM, or additional entity called necrotizing myopathy, adult dermatomyositis, or DM, or additional entity called amyopathic dermatomyositis, juvenile dermatomyositis, cancer associated myositis, which is mostly cancer associated dermatomyositis, connective tissue disease associated myositis, and inclusion body myositis. When we evaluate patients clinically, it's not always clear which subtype of myositis the patient may have. Now, it's clear many times, but many a times it's not very clear. In those circumstances, when it's not clear, given that autoantibodies are generally specific to underlying clinical subtype, it can help identify which of these clinical subtype that we might be dealing with. Another important concept to remember is that myositis is not a single diagnosis. As we've discussed, it's a bunch of different disorders put together, and within each disorder is actually does not affect one single organ. It may affect different organs, and each individual patient might be different from another patient within that subtype even. So it's important for us to recognize what might be going on in our patient and what may come in future so that we can plan appropriately and manage that patient appropriately. As you can see in this slide, myositis can cause weakness, lung involvement called interstitial lung disease, can cause joint pain and swelling, arthritis, can cause severe rashes as in case with dermatomyositis, can cause calcium deposition under the skin called calcinosis, can cause fingertip changes called Raynaud's, can cause difficulty in swallowing, and various other manifestations. Now, how do a physician know which of these clinical manifestations are going to be the most problematic features in his or her patients? This is again where autoantibodies are very helpful because each autoantibody predict a unique clinical feature that the patient may have or may develop in future. So knowing an autoantibody can be very powerful for a physician because they can almost predict what problem or clinical issues that the patient might get into and can monitor and treat aggressively for those problems. Now, as you may know that there are various treatment options available for myositis. Not all of them are highly effective, but at least those are the options that we give to our patients. Myositis doctors often don't know which particular treatment would work for their patient A versus B. This is again where myositis autoantibody knowledge can really help to understand which treatment may have a higher likelihood of working in a patient A versus patient B. Currently, we use the help or the knowledge of autoantibody in starting the treatment. For example, if a patient may have necrotizing myopathy, I might be more inclined to treat that patient with IVIG as compared to anti-synthetase syndrome antibody, in which case I might be more inclined to use rituximab. In this slide, I have summarized some of the points we have discussed so far about why myositis autoantibodies are important. First, myositis autoantibodies are highly specific. therefore helping in diagnosis. Second, myositis autoantibodies are associated with clinical subtype of myositis. Third, they represent a homogeneous group of myositis patients with unique clinical features. Third, there are powerful predictors and prognostic tools regarding future clinical problems or manifestation as well as treatment responses. And last but not the least is myositis autoantibodies are associated with long-term prognosis, including the survival in our patients. On this slide, I have shown myositis autoantibody subsets. Basically, this diagram is a little confusing, so I want to walk you through this diagram. Essentially, this circle is divided, the bigger circle is divided into three main components. One is polymyositis, other one is dermatomyositis, and the third component is overlap myositis. Within polymyositis or PM, it's also subdivided under necrotizing myopathy. Now, you see that on this bigger circle, there are many bubbles, and each bubble represents a unique myositis autoantibody that have been discovered and are known and can be tested. As you can see in dermatomyositis subset, there are 5 different myositis autoantibodies that could be present. Similarly, in polymyositis, one of the major autoantibody circle actually is anti-synthetase syndrome, which is a purple circle under which there are many anti-synthetase antibodies. There are actually currently 8 anti-synthetase antibodies that are known, with Jo1 being the most prominent of those. And also under necrotizing myopathy, we have 2 antibody subset, SRP and HMGCR antibody. And there are few antibody subset under overlap myositis. In the remaining time, I will discuss some of the key or myositis autoantibodies that has been discovered one by one. First, we will talk about the autoantibodies seen in the clinical subset of polymyositis or necrotizing myopathy. Under this subset, one of the major category of myositis autoantibody is anti-synthetase antibodies. This is the largest group of myositis autoantibodies seen in myositis and has unique clinical features. Under this anti-synthetase antibodies, actually there are multiple different autoantibodies, amongst which Jo1 antibody is the most common and well-known antibody. This slide summarizes the clinical features of anti-synthetase syndrome, which obviously include muscle weakness and rash because that's typically what defines myositis, but also include clinical features such as mechanic's hand, as shown on the left top corner, as well as arthritis, as well as fingertips changing color in winter or on exposure to cold called Raynaud's, fever, and last but not the least, in fact, the most important clinical feature of antisynthetase syndrome is the lung involvement called lung fibrosis or interstitial lung disease. Interstitial lung disease is the most common feature of antisynthetase syndrome, even more common than the muscle weakness itself. In fact, studies suggest that 70 to 90% of patients with antisynthetase syndrome may have interstitial lung disease, as compared to only 50 to 70% patients with myositis. We did a study at University of Pittsburgh in which we studied about 229 patients with antisynthetase syndrome, and what we found is although Jo1 was still the most common autoantibody in this antisynthetase syndrome patients or antisynthetase antibody patients, but there were 5 other antisynthetase antibodies that we discovered in our population, and those were PL12, PL7, EJ, OJ, and KS. Now, these 5 antibodies that we discovered, we collectively called them as non-Jo1 antibodies. And overall, they represent about 40% of our cohort. So sometimes some doctors only check for Jo1 and not for all other antisynthetase antibodies, and that could mislead in 40% of the cases. We may not know that the patient actually have anti-synthetase syndrome in 40% of those cases if we only check for JO1. So I appeal to the doctors generally is that make sure you check for all myositis autoantibodies, and if you suspect that the patient may have anti-synthetase syndrome, please check for all anti-synthetase antibodies and not just JO1. Anti-synthetase antibodies patients typically respond very well to steroid and other immune suppressive agent. However, when the immune suppression or steroid are reduced, they tend to flare up very quickly. Some studies have suggested that using rituximab in more difficult to treat patients in anti-synthetase syndrome might be beneficial. Next, we will focus on necrotizing myopathy autoantibodies, amongst which there are two antibodies. One is called SRP, another is called HMGCR. First, let's discuss anti-SRP antibody patients. In the anti-SRP subsets, these patients or patients with these autoantibodies are typically younger patients. They generally have acute onset or sudden onset of severe weakness with severe muscle pain. Their muscle is the main problem with weakness and pain, and generally it does not affect the other organ system such as lung, arthritis, rash, and so on. When we check their muscle enzyme, they have a very high level of muscle enzyme called CK or CPK, and because of the severity of this illness, they develop early muscle atrophy. They could also have severe swallowing trouble called dysphagia, in difficulty in eating and solids mostly. And also because of the severity and aggressiveness of this disease, they generally portend a poorer prognosis and are often refractory to usual first and second line treatment. A typical story I tell my students about anti-SRP patient is generally a young college student, or early in their job, young patients who were otherwise very healthy and might be running a marathon or playing basketball on a regular basis, and then within a couple of weeks, once they get hit with this illness, gets to almost wheelchair within few weeks and with severe muscle weakness and very high level of muscle enzyme called CK and diffuse muscle pain along with difficulty in swallowing. When we do muscle biopsies on patient with SRP antibody patient, what we see is muscle fiber death, in fact significant muscle fiber death or necrosis um, without much inflammation. Now this is very different than what we see in polymyositis. In polymyositis, typically muscle fiber death is due to the attack from the inflammation. Given the typical pathology of this necrotizing myopathy, we have now taken out the necrotizing myopathy from under the polymyositis category, and it's now its own entity of necrotizing myopathy. Next, we will talk about an interesting autoantibody called HMGCR antibody or HMG coenzyme reductase antibody. HMG coenzyme reductase is an enzyme which is inhibited by statin, which is a common drug used for management of high cholesterol or cardiovascular disease. Typical drugs available for statin would be some like simvastatin or lovastatin and so on. This autoantibody is associated with immune-mediated statin myopathy, which is a type of necrotizing myopathy secondary to statin. This develops generally during or after the statin exposures, obviously in the patients who are taking statin for cholesterol or heart purposes. When this myopathy develops, the patient develops weakness and they continue to have weakness even when you stop the cholesterol lowering medicine, which is the statin in this case. Their weakness could be mild to severe, and they typically may have some muscle pain along with some joint pain and difficulty in swallowing. They have generally very high level CK, as we have seen with SRP necrotizing myopathy, and the biopsy looks almost identical to the SRP necrotizing myopathy. Again, this can be easily identified by an autoantibody called HMG-CR antibody, and most of these patients respond well to immune suppressive agents. But typically, if we stop the immune suppressive agents such as steroids and other immune suppressive agent, it tends to come back. In this entity, what many researchers, including us, have observed that a drug called IVIG or immunoglobulin works really well for these patients. Next, we will discuss some of the key autoantibodies seen in dermatomyositis patients. First, we will talk about anti-MI2 or Me2 antibody. It's one of the most common dermatomyositis autoantibodies and is generally a classic dermatomyositis patients. These patients typically have milder disease and classic features of skin rash and muscle weakness. Generally, this antibody has good response to treatment and often don't have other clinical features such as having lung problem or other problem. They typically have classic rashes and muscle weakness and responds well to first or second line treatment. They commonly would have Gotten papule or heliotrope rash, shawl sign, or V rash on the chest, and periangle redness or redness around the nail fold. Having this autoantibody basically then means it's generally a good prognosis. That means these patients are going to do very well in the outcome, and this disease can easily be controlled by generally the first line medications that we give for dermatomyositis. Now, from a very good clinical phenotype or clinical presentation of an antibody, I want to talk about a slightly different clinical entity called clinically amyopathic dermatomyositis patients, which basically means that these patients has classic skin rashes of dermatomyositis but no muscle weakness. That's why they're called amyopathic, which basically means not involving the muscle. There is an antibody called anti-MDA5 antibody, which is highly associated with this CADM or clinically amyopathic dermatomyositis patients. Now, this autoantibody, if you have this autoantibody, is associated with very poor outcome, at least in US, as well as South Asian studies have shown that having this autoantibody leads to significant death early on, within few weeks to months to within a year. A lot of patients, we lose a lot of patients mainly because of severe progressive lung disease that these patients may develop. As shown in this graph, I'm showing you the survival of MDA5 positive patients actually drops rather quickly to about 70% from 100% within the matter of 1 year. Whereas if you are MDA5 negative, if you don't have that antibody, you kind of have a slow progression over time, over years. And obviously we lose patients over years with other problems. But if you have MDA5 antibody, then we lose them rather quickly because of progressive lung disease. Next is another antibody called anti-TIF1 gamma antibody. Now, this antibody is highly associated with cancer-associated dermatomyositis. This autoantibody behaves differently in adult as compared to juvenile dermatomyositis or in kids. In adults, this is associated with severe skin rashes of dermatomyositis and underlying cancer associated with myositis. Now, understanding cancer association with dermatomyositis is rather important. So, some patients actually develop cancer first and then led to the clinical features of dermatomyositis. Obviously, in those patients, we cannot detect the cancer because cancer has already been diagnosed. But in many patients, patients present with dermatomyositis and may actually have an underlying cancer which has not been discovered yet. In those cases, having knowledge of this autoantibody can really help because the doctors can look hard for that underlying cancer if they already have the knowledge of this antibody by doing PET scans or CT scans or other investigation. Now, doing these investigations are helpful because if you can detect cancer early in these patients, that might actually improve the outcome of that patient because cancers treated early have much better prognosis as compared to cancers treated at a later stage. Now, in kids, although they may have the severe skin rashes of dermatomyositis and calcinosis, but typically they are not associated with any underlying cancer. So, the same antibody in adults associated with cancer and the same antibody in juvenile patients is not associated with cancer. Then now the summarizing slide. Here I have shown all the myositis specific autoantibody or most of them, and I've shown how each autoantibody subset defines a clinical feature that can help the physician as well as outcome and treatment. So in the first column I've shown anti-synthetase clinical features as well as autoantibodies associated with it, followed by necrotizing myopathy and the autoantibody associated with it, followed by amyopathic dermatomyositis and the autoantibodies associated with it, followed by dermatomyositis associated with cancers, underlying cancers and calcinosis or severe skin rashes, and the autoantibody associated with it. And last but not the least is dermatomyositis associated with good prognosis overall. So, in summary, I hope I've shown that how myositis autoantibodies help in the diagnosis and ruling out some of the mimickers of myositis. Having this autoantibody can help in confirming an underlying diagnosis if the diagnosis is in question. Also, these autoantibodies can help in defining a disease phenotype or how the patient would present or what clinical features the patient could present. For example, TIF1 gamma being associated with cancer, anti-SRP having severe refractory muscle disease, anti-synthetase antibody associated with interstitial lung disease, and so on. Next, we can actually use these antibodies as a prognostic marker. Having MI2 is a good prognostic marker. You're likely going to have a good outcome, and having anti-MDF5 antibody is a bad prognostic marker because we lose 20-30% of patients early due to progressive lung disease, and can also help in predicting treatment responses, as I previously talked about, using rituximab for anti-synthetase syndrome or IVIG for necrotizing myopathy or anti-HMGCR antibody. With that, I want to thank you from Pittsburgh Myositis Center, and I welcome any feedback that you can provide me on the talk. Thank you.